I have a couple, Jeff.
All right.
Okay, trying to make this thing get out of the way. On the radiograph here on your right, I hope you can see a radiograph. This woman with CVID has a vague nodule up here, which persisted for several weeks. And here's what it looks like on your left here on CT. So nodule on the left apex. We look at the rest of the lung. Nothing too remarkable. A lot of people with CVID will have more bronchial wall thickening than this person has, so it's very mild if present at all. And this needle biopsy was performed on this nodule, and it revealed Cryptococcus. So about half the cases of Cryptococcus are associated with some sort of immune deficiency. Sometimes it's corticosteroid treatment, sometimes it's more basic, as in this case, CVID. We were not able to get it on culture, and so we don't have it speciated, but it's probably Cryptococcus neoformans. Out here, it could be Gaddii. That'd be a possibility too, but we don't have any further evaluation. She got better on antifungal therapy. Okay, let me show you a diaphragm case. This person, this was outside B reading, and the person had this mild eventration here of the right hemidiaphragm at this point. And then later on, there's a much more discrete abnormality here of the right hemidiaphragm contour. And you can see that it has an undercut margin, which you would not expect for eventration. Eventration should flow back into normal diaphragm height. And this one is undercut, implying that this is more likely hernia with a mushroom above and a collar sign perhaps on CT. So it's an outside case, but we were able to get a hold of CT, and it's indeed, this is a hernia of the right hemidiaphragm. You can see that the normal diaphragm muscle sort of goes into the side of this lesion and bulges out above that height of the normal diaphragm. The diaphragm doesn't go over the top the way it would in eventration. So this is indeed a hernia, a strange kind of hernia of the right hemidiaphragm. And here it is on lateral, once again with the diaphragm going into the side and this thing bulging above. So this person acquired a hernia of the right hemidiaphragm. So diaphragm is a wonderful and fascinating muscle, very important it turns out. So here's a person who had several rounds of neck surgery. So she'd had neck surgery in the early 2000s because of disc degeneration and nerve compressions on exit and so forth. So she had ancient surgery, and then in 2018 or 2019 she fell, and she had a lot of neck pain during this after this fall, and I think she might have had another round of neck surgery at that point. So this is her current, a reasonably recent current radiograph. So she has this elevation of the right hemidiaphragm. And usually the cause of elevation of the right hemidiaphragm is eventration, which means that posteriorly the diaphragm should be back to normal height. In her case, you can see the diaphragm remains elevated all the way back to the posterior chest wall. And this is a pattern you see with elevation caused by phrenic nerve dysfunction. So this implies that she's got a right phrenic nerve problem. And she had a CT scan around this time. You can see that she has normal thickness of the crus of the right hemidiaphragm. And she's got a very thin crus of the left hemidiaphragm. So this really looks pretty atrophied on this side. And you know, you'd expect that her abnormality, her dysfunction should be on the left, and the right has surprisingly normal looking crus here. So it really does not look atrophied, corresponding to the paralysis you would expect based on her chest radiographs there, the elevation really looks like paralysis. So she got a sniff test, and this is with the patient standing at the beginning, and you can see that on deep inspiration she has decent excursion of both hemidiaphragms, and that as the diaphragm goes down, the chest wall goes up. So everything looks hunky-dory. And then on lateral view, you see she also has not great, but reasonable excursion of both hemidiaphragms, and the diaphragm moves down as the chest wall moves up. So diaphragm down, chest wall up, that's the way it should be. And then we return to the frontal position and observe her standing. He has, again, this about a half a rib or 2/3 of one rib interspace excursion. I consider normal to be about one rib or more. Looks pretty good. And then we put her at 45 degrees and then eventually supine. So this is the same person now supine a few seconds after we got those standing views. And now look what happens when she tries to take a deep breath. She has almost no function, no excursion, orthogradient excursion of either hemidiaphragm. As a matter of fact, if you look carefully, the diaphragm is actually moving up when the anterior ribs go up. So the chest wall motion is actually dragging the diaphragm up. There is no muscle function here on either side. So this is profound. This is bilateral hemidiaphragm paralysis that you would not suspect unless you got supine views. So supine is really important. And what's the cause of all of this? And how do you explain? On the left, we could explain the findings easily. She has a very thin crus, really does look like a phrenic nerve paralysis. On the right, how do you explain the normal thickness of the crus, but this profound dysfunction? And the answer was revealed when I had one of our neuroradiologists go through her outside neck MRI studies. And he said that she had cord compression at C3 and C4. So what we're seeing here is the effect of upper motor neuron disease on diaphragm, causing diaphragm dysfunction. But because the lower motor neuron is intact and connects to the muscle is not atrophied. So one of the findings, I reviewed the chiropractic website, and it says one of the findings of upper neuron disease is that you can have muscle dysfunction without atrophy. So that's what we've got going here, guys. The lower motor neuron is intact, the crus thickness is preserved, but there's profound dysfunction of the diaphragm here, really bilateral paralysis with normal crus thickness on the right. So upper motor neuron disease and myopathy are two situations in which I've seen normal crus thickness, but profound dysfunction. Okay, guys. That's all I wanted to harass you about this week.
That's really cool. Thanks, David. Okay, Travis, you want to go next?
Yeah, just one quick case here. Thanks. And David, hopefully this dovetails nicely with yours. So this is a lady who has had radiation and maybe chemotherapy for left upper lobe lung cancer. And you can see there's some volume loss there and fibrosis that's developing. And David and I did not plan to show these cases together, but you can see at the right posterior lung, there's this peculiar thing that pooches out and looks a little bit lower attenuation than the liver, but clearly it looks like it's inseparable. And we've seen, you know, and if I show you here, you'll see it has a little bit of that kind of a collar appearance to it. You know, back when I was in residency, there was one case very similar to this that did get biopsied and obviously returned normal hepatocytes, which was a surprise to the person who did the biopsy, but not a surprise once you actually, you know, if you looked carefully at it. But I'll show, you know, this part comes into play here. You can see with contrast, clearly looks like it's portion of the liver, no surprise. Then this was where this came to our attention. So this patient had just a routine restaging CT, and now at the right lung base, you can see that that area is curiously absent. And there's a little bit of atelectasis or scar in the lung, and then the diaphragm just looks kind of funky there. So we were trying to figure out what happened. Because a lot of this was done on the outside, and we were trying to figure out, did they think this was a MET and resect it, or did they think it was a MET and irradiated, or some sort of other tumor? But to cut to the chase, I finally found this key study. So this was done, this one that I showed here was done in February of 2020. 1 month later, you can see 33 days later, this patient presented to an outside hospital with this, and no intervention had been done at the time, but as you can imagine, she had severe onset, or relatively abrupt onset, of severe right upper quadrant pain, and she had other GI symptoms of obstruction. And you can see now that she has colon that is herniating through that little hernia that previously contained only liver. And this was spontaneous. I have never seen this before with just one of these little tiny liver hernias, but she did have to go to the OR, and this was ischemic gut that had to be resected. So she has, on this more recent one, I don't know if we get down far enough, but you can see a little bit of strain here, but she did have to have a partial colectomy and anastomosis. So David, you know, I know I've seen a few of those just like yours. I've never seen this before, but it, you know, in some cases, maybe it is a little, you know, maybe it's a ticking time bomb in some of these patients.
Do you think, I mean, this lady hadn't had any abdominal surgery that might have nicked the diaphragm, or had
Nope.
A liver biopsy or something, a needle biopsy of the liver or anything like that?
Nope. That's what's so fascinating about it. This is 1 month before, and there was nothing that happened in between. I checked, there's no trauma or anything. She just developed sudden onset of pain. And you can see she doesn't even have colonic interposition, you know, or anything here. So I have no idea how that got up there. You can see she still has her gallbladder. So, yeah. But pretty interesting case. But fortunately, she did okay.
Cool.
Very, very strange. It's very perplexing. Can't figure out.
But it does underscore what David was saying, that this is not just an eventration. This is a hernia. So that's my interesting case for the week.
Thanks. I'm going to show mine quickly. Let's see. That way I can leave. Okay, so I'll start with this one. This is just a nice case. So this patient presented with chest pain, and I'll show you. These two radiographs are about 2 weeks apart, and you can see the aorta. I always forget which one is which. There we go. Anyway, the patient presented with chest pain, and you can see it looks relatively similar. The aorta is tortuous. There was really no change. So we ended up doing a CT scan looking for some acute aortic issues or pulmonary embolism. And here we can see a really nice dissection. And this one is kind of cool because you can see the true lumen here is quite small and goes all the way back to the valve there. It spares the coronaries. The coronary ostia are open. And what else is kind of neat is there's a nice, when we've seen these before, this blood sheath along the adventitia of the pulmonary artery. And I think at the time this was done, there was a question potentially was there hemopericardium, but I think when you look on the coronals, and they're brighter, you can see the soft tissue going around the pulmonary artery and is not filling the rest of the pericardium. But what's kind of cool is I read on the op note, they found the initial tear was actually at the level of the arch, which is kind of a rare location. But I think in retrospect, that is probably at least part of the tear there. And then it created this sort of floating little true lumen going down there. I know Howard showed one that looks like the whole intima is just hanging out, flapping in the breeze. And luckily, when they were in the OR, it got to the valve, but it didn't involve the valve. So they were to resuspend the valve leaflets and save it, put it in an ascending graft, and then the patient did fine. But just a kind of a neat looking dissection. The really compromised lumen there, but it opened up later on. So
surprising the patient didn't stroke out, given
yeah,
how
I should show you up high. Yeah, there's the carotid here. It's
carotid, but I mean, there's no flow. I mean, the true lumen in the ascending aorta is almost gone.
Yeah.
So it's relatively slow flow throughout that.
Right.
I guess it was enough to perfuse the brain. I guess they're
Yeah.
lucky.
Yeah, no, it was one of those ones. But it was kind of crazy because comparing the two radiographs, there really was no change. All right, this is a fun case. I got to get these all in the right order. So this is a 61-year-old female who was on a TNF-alpha inhibitor for, I want to say, rheumatoid arthritis, and over the course of a while developed some nodules in the lung, maybe a pleural effusion on that radiograph, and then went on to have a CT scan. Let's get the dates right. Here we go. And you can see there's pleural effusion at that time, and then there's all this lymphadenopathy, and then this area of consolidation with this, what looks like an abscess or area of necrosis in it. And this was eventually biopsied and grew out a fungus that I had not heard of before called Alternaria. And Alternaria is a common fungus that if you ever have a garden, it causes leaf spots. That's, I think you'll see on tomatoes and squashes and stuff. And it just, you can see, ended up being all of these nodules and masses. This was after some treatment, but it can cause disseminated infection in immune compromised patients. It would be unusual just on a TNF-alpha inhibitor, but caused these multiple masses in there.
Wow.
Had a more recent one. Let's see. That was after some treatments. It was getting better. Yeah, it got pretty ugly. This was it at its worst. So this area of like mass-like consolidation, and then all these other nodules spreading out. I mean, it looks like any other nasty fungus, aspergillus, has some airway component there. But interesting, David, they sent it to the University of Washington to speciate it.
Mm-hmm.
So Alternaria, yeah. So I looked it up, and the first thing you get is like all leaf spots. But so most cases that are reported are cutaneous infections in gardeners and horticulturalists, but it is a cause of reported cause of human lung disease. But it's usually more immune compromised patients. But it responds to antibiotic, the right antimicrobials. But
So, Jeff, what was her immune compromise that had her on the anti-TNF?
she had rheumatoid arthritis.
All right, okay, got it.
All right, yeah. So not heavily immune suppressed, but enough to affect T cell function in response to fungus.
You know, I have seen that organism here. I'll try to pull a case, but it has come up before in infectious disease in our transplant population.
Yeah, it's the first I've heard of it. So this is a fun case. So many images on this patient. This is a patient with asthma who presents with chronic cough and has had a bunch of radiographs. I want to find the one that shows, yeah. So here's one here that shows a really nice upper lobe collapse. And then on a later radiograph, we can see the right upper lobe has opened and now the left upper lobe has collapsed. And I should have a lateral view for that one right here. So we can, yeah, you can see the fissures moved anteriorly. There's the collapsed left upper lobe. And going back to the frontal, you see that subtle lift-sickle sign. There's not a ton of volume loss. There's leftward shift to the heart. The diaphragm is not pulled up, but the hilum is. And it has that haze. But what's kind of cool is the CT is just spectacular. And we've got 15 years of CT scans. But here's that right upper lobe collapse back then. And if we switch to the lung windows, you'll see there is central bronchiectasis. There's this funny cystic thing there, a little bit of lingular collapse, but a nice central varicose bronchiectasis. So as you imagine, with asthma history, you think about things like ABPA. And here is that right upper lobe 15 years later with just this spectacular dense mucus plugging, about as good as it gets. I don't have a CT on the left upper lobe collapse because you really didn't need it at that point. But this is just there's a series of radiographs in here that shows sort of alternating lobar collapses because of mucoid impaction on a background of bronchiectasis from ABPA. But this is some of the best mucus plugging I've seen that really just shows how dense it is. And then this last case is, I know we've seen a couple of these. So this patient was transferred to our hospital a while back for a seizure, had a recent aortic valve replacement or repair, I can't remember, the aortic valve surgery, and a maze procedure for atrial fibrillation, and was sent here for management of a seizure. And the patient then had an arrest later on during the admission, and this was one of the head CTs that was done. And you can see, if I scroll up, there's some gas in the brain where it ought not to be. Now, this brain doesn't look normal. There's ventricular dilation and all that, but clearly what looks like gas in the brain from an embolic source. So further investigation, there was a bump in troponin as well. They were looking for all sorts of stuff. But what we'll see here, and it's a very subtle finding, is, so you can see there's an NG tube in, is this little, let me make it a little bit bigger, is this little bit of gas right here within the wall of the left atrium or in that general vicinity. And there's a little thrombus here in the left atrium. So with the maze procedure, of course, that would have been in the left atrium. And this was about a month later, so this was not immediately post-op. Patient had been in rehab and then had the seizure. So they were worried about clearly embolic stroke, the troponin may be from that as well, but with this gas and the gas in the brain, clearly there's got to be a fistula from somewhere. And we don't see any direct connection, but as you can imagine, if you saw gas communicating right there, it would probably, patient would not be alive to see that. And there's the valve there. But ultimately, the patient did die from this. And on the autopsy report, they reported a small fistula between the left atrium and the esophagus. So this is a rare complication of a maze procedure. I looked it up. It reports it anywhere between 0.06 and 1%, which is quite a big range. 1% is not insignificant. We've seen it with RF ablations and other instrumentations like that, but this is the first one I've seen following a surgical maze procedure, but it is a rare complication, and the finding is extremely subtle. I'm not sure exactly where this gas is hanging out. If maybe there's thrombus here and it's sitting up against it, or if it's truly in the wall or where, but the esophagus is way over here. So unless this is a little track or something, but.
Or it's just in the pericardium next to the left atrium.
That's a good, yeah, that's actually, I think you're probably right there. But the presumption is there's a fistula. I think the brain imaging makes it clear. I looked in the coronaries, I couldn't find any gas. I suspect it would be micro bubbles that would cause the bump in troponin, because a big bubble would cause a much larger infarct. So just a rare complication, a month out, and they can, in the literature too, it reported them anywhere from a few days to several weeks. So it's not outside the range. It can be a delayed complication. All right, and that is all I have. All right, let's see, we got Seth and Howard.
I can go quickly.
All right.
This is a case I had the other day from the emergency department. Looks like a iatrogenic breast implant. You can see a massive air collection in the right breast. Here is the CT. So I had to, after a while, figure out what was going on here. So there's some sort of cavitation with surgical material in the right lower lobe there, but in the right middle lobe, there is a bronchus, which I will get to soon, which has a endobronchial valve in it. And we can see that there's this bronchus basically leads to this big, what presumably was a piece of bronchus at some point in time, but now is this big air collection that then communicates with the pleural space and then communicates as well with the right breast. You'll see there's a tract going inferiorly and connects with the right breast. So, but there's the other tracts, and there's another endobronchial valve in the right upper lobe. Sorry, this thing is just slow when I'm doing it from home. There's another endobronchial valve in the right upper lobe bronchus. So this all stemmed, gonna have to go back in time here. This all stemmed from, patient had a diagnosis of colon cancer and had metastatic colon cancer. And they decided she had 2 mets in the lungs. Now, one was in the right middle lobe here, and you can see that they have their whole, I mean, again, I don't know if this was the best technique. I don't do ablations, but their probe is basically still in the wall. Portions of it are still in the wall. There's a lot of burn here. I mean, this is a big, big injury here that they caused. They probably weren't getting good enough rise in temp if they did it with microwave. I'm not even sure how they did it, but because it's so, they were so central. Anyways, big burn here. They also burned the right lower lobe. This is the follow-up for that, and you can start seeing. So here is this consolidation, which is kind of, and then we start seeing that there is this communication between this big area burning with the bronchus, then going into the chest wall, and the right lower lobe showed similar findings. And let's see here, I don't remember what this was. This will even download all. Let's see. A lot of these are outside studies, so I apologize if they're not the best image quality. So there's the site of burn in the right lower lobe, which actually looks pretty good. And then here is the right middle lobe, and it actually looks like for a while it closed down, the scarring, but then at some point in time, it opened way back up, and she actually developed a big fistula. So now this is about 16 years later. So she disappeared for a bit. Oh, man, I got kicked out. Sorry. Maybe my system kicked me out. Super. All right, why don't you
Go on to
me for
Howard
now.
and come back.
I don't know, who knows what just happened. Okay, thanks.
All right. Okay, Howard, I'm going to give you control.
Okay, this one is interesting. I'll start with the chest radiograph, and I'll put the lateral alongside it. It's an interesting finding. It's really subtle, but it's nice. So let me try to separate these and do this. So I'll give you some history. Chronic cough, persistent for many years. And there is an important item of historical information that I'm hiding for a moment. I'll give you a moment to look at that. And I will go to actually bring in the area of interest to the middle and look in this region. Really subtle, but it's interesting. And assume for the moment that if we had multiple radiographs, I only have one, that the finding might be present on all of them. So just for trainees in particular, anatomy, this is trachea. And here is air in the trachea. And here we seem to have a atrioesophageal stripe, but we also have an unusual stripe here with some air right here. And there is really subtly a bit of air right there. So if that is persistent, the patient has a cough, and now I'll give you the relevant history, which is that she had a TEF, tracheoesophageal fistula, repaired in childhood. Now we go to the CT and recognize that what we see on radiography is air in the esophagus, air in the trachea, and we have the fistula. So there it is right there. So it's a recurrent TEF. Now she's had this for many years and has tolerated that discomfort for a long time. You can see the history here. She's 25. The history of persistent abnormality symptoms, and I think I can fix that. I'll try to fix that by doing, seems silly that here they did a bronchoscopy and endoscopy to confirm the presence of the fistula between trachea and esophagus right there. So I presume they're going to repair it at some time, but kind of a nice complex of findings.
Did they have any idea why why it recurred?
Don't know.
Hmm.
No. Don't know, Jeff. Just
Okay.
broke down, maybe, and
Yeah.
then just stayed. And the patient has tolerated this troublesome cough for a long time. Well, to a point, obviously. Yeah, interesting. So this is, correct me if I'm wrong, the H-type fistula, typical location.
Sounds right.
H-type TEF that the pediatrics books talk about. Okay, this is a patient with a mass discovered on radiography. Apparently, the patient was not symptomatic, apparently. So I'll give you a look at the appearance of it just by scrolling through fast. So here is the nasty looking mass, and you can appreciate its vascularity, appreciate variable contrast enhancement of the lesion, and even has a bit of calcium in it. The patient on the outside was actually described as having subcoronal lymph node disease, but this actually is of low attenuation and is quite consistent with a cyst. So that was biopsied and removed. Let's just quickly look at the PET. Not super hot, and then you can see areas of necrosis within and the calcium. So this is a solitary fibrous tumor with pretty typical biopsy findings, and typically, just as is typical, STAT6 positive fibrous tumor. There was a fair amount of necrosis, and it seems like the pathologists described that in terms of the potential behavior of this lesion over time, and that was removed.
So I have a question for the group, because I mean, I don't know how many, I've seen 30 or so of these over the years, and you know, they describe based on mitoses and the risk. Has anyone actually ever seen one metastasize or become aggressive, other than just the mass effect of the large ones that are subsequently removed?
Yeah, I showed one a long time ago that was very malignant, actually, generated some malignant, actually metastasized.
Okay.
I could try to pull up that case and show it. It was
yeah,
quite.
I'm just thinking it's because you know the literature always says a much higher number, but if you've seen one, and among all of us, who knows how many of these we've encountered, I've just not seen one recur.
So was it local recurrence when you say metastasis, or was it two remote sites?
There was lung metastasis in multiple sites that were biopsied and showed to be the same histology.
And it wasn't a sarcoma.
No. Well, they degenerate, and they had malignant degeneration, the fibrous solitary fibrous tumor, but it wasn't a. I mean, again, when there's malignant degeneration, I don't know what the degeneration is into. It may degenerate into a sarcoma, but I could dig up that case and show it. It's a nice case. But
yeah, I'm just curious because you hear about it, but like I said, you know, you've got one example, and among us, unless there's other people that have seen one, but
it was really big. It was filled.
I've seen a case here, at least one, that was resected and then recurred and spread around the pleural space and was a real mess. So that was considered a malignant kind, and it did spread, but it was local.
Yeah.
Yeah.
This one also recurred locally too, but there were hematogenous mets.
Good. These next cases are kind of interesting because, particularly for trainees, when the radiograph doesn't really show an explanation for what is substantial respiratory impairment in these patients, that is with respect to their symptoms and PFTs. So here's a frontal and lateral projection of the chest. Give you a moment to look at that. The patient is a smoker. You know, in looking for large bully and attenuated vessels, we don't see that. Not that impressive in terms of overinflation at all, but pretty impressive, as you'll see here, findings of smoker's lungs. So we have a lot of emphysema. I don't know why, but a striking amount of paraseptal emphysema in addition in this patient. And certainly one can ascribe the diffusely hyperattenuating lungs to the accumulation of smoker's macrophages in these lungs. So very severe smoking lungs, certainly an adequate explanation for substantial respiratory impairment in this person. And I don't know why we have such dramatic paraseptal emphysema in the peripheral lungs like that, but really interesting. It's mucus in the airway there. And then the next one is the same kind of situation. So a patient with substantial respiratory impairment has a radiograph that looks like this, and a lateral projection that looks like that. Doesn't look that abnormal. And then on CT, we have, now I don't think I have thin cuts from the outside CT, so I'm going to show you these. And I hope it shows up there, but we begin to see some abnormality related to small airways, some mucus and bronchi, but I'm going to try and bring out the main finding, which is mosaic attenuation. And I'll show you the expiration in a moment. That'll really bring that out. So we do have bronchial wall thickening and that, but let's just look at these in order. Here's a nice example of mosaic attenuation, air trapping, substantial abnormalities, substantial air trapping. So this person did receive a lung transplant, and the diagnosis of constrictive bronchiolitis sporadic was confirmed on examination of the explanted lungs, but this is a pretty nice teaching case of sporadic constrictive bronchiolitis severe. You know, the patient's trying to really expire here. You can only empty your lungs so far when the disease is severe.
And you
so
said
constrictive bronchiolitis.
Idiopathic?
Presumably idiopathic, yeah, as far as I know. One can get some degree of central segmental airway dilatation in constrictive bronchiolitis. So that doesn't faze me that we have that in a person with chronic constrictive bronchiolitis. All right, those are my cases, Jeff.
That's a nice example. Seth, are you back up and running?
Yeah, I'm back.
All right.
All right, just to finish off this case. So anyways, this patient had developed presumably a bronchopleural fistula in the right lower lobe as well, but then this bronchopleural fistula, which actually initially they packed with some sort of surgical material and exited through the chest wall and exited anteriorly here. You can see the track. And they went in at our place and resected the track that was there going to the anterior chest wall. And they took out the surgical material and put in these endobronchial valves, but when they closed off one pathway, another opened up. So she wound up, so you can see here's a little bit of the residual of this path that they ligated, and you can see a little bit of air there, but then, you know, every time she's breathing, she's basically pumping air into these endobronchial valves. I don't know. I have not seen them be very effective for anything, let alone a massive bronchopleural fistula. But so every time she's breathing, she's basically pumping air, and it's just going to find a track, and it found a track into the right breast, and she's basically has a massive fistula between basically the right mainstem bronchus and her right breast, and the hole that drains out of is right in here. So unfortunate case of probably a little bit over aggressive RFA ablation. And here's the right lower lobe thing, which is expanded and started filling with air again with the surgical material. The only reason I can imagine they did that is in the 16 years intervening, this developed a fistula as well. Let me go to this case because this is up and it'll be faster because it's on this system. So this is a patient with who had ABPA, status post repair. She has some other congenital anomalies. You can see this is not a normal PA. She had a PA valvuloplasty. It doesn't look like she had a Ross procedure. I'm not really sure if she was pulmonary atresia with intact ventricular septum. I can't remember what she was. Anyways, long story short, she had repair of the pulmonary valve. They did some repair there and started kind of having a little bit of shortness of breath, and they got another CT, and this is very subtle, but what you can see is, and maybe if I can pull up both without completely screwing this up. So what I want you to notice is, so this is a SA nodal branch here, and that's the normal size of an SA nodal branch. And then when I initially kind of looked at this again, when I saw the history, because I was reading a chest X-ray, I initially thought this was going to be a retroaortic right circumflex, which is probably the rarest coronary anomaly. I've seen one, and it was in a single coronary. The retroaortic circs are quite common. But you can see this is not a circ. It's actually the SA nodal branch. And the SA nodal branch went from this tiny little vessel to this absolutely, you know, it's not huge, but for an SA nodal branch, it's absolutely massive. And then you could see it kind of here, almost look like it communicates with the left atrium, and then it gets small in size again. And, you know, again, this wasn't picked up prospectively, you know, which I understand it's small, but whenever you see a big vessel, it doesn't matter. I mean, again, it's a small vessel, but a vessel is much bigger than it should be. You should always think about a fistula. Anyways, they took the patient to cath because they saw something on echo, and you can see, sure enough, there's an SA nodal to left atrial fistula here. You can see the contrast pumping from the SA nodal branch into the fistula. Now, what's fascinating about this is that no one's really sure how the hell this developed, because they didn't go back there with the surgery. They didn't muck around anywhere in the back. They did a repair, an anterior approach repair of the pulmonary valve. So no one's really sure, and you can see that there's a little bit of change anyways. So no one's really sure how they got the fistula, which between, you know, the preoperative and the postoperative, you know, someone was questioning maybe it was cross clamping of the aorta, but that would be really weird to get the, anyways. So an acquired fistula from a weird vessel to the left atrium. So that's, I thought was a very interesting case. And